be here this afternoon to speak with you about improving outcomes in our treatment for women with depression. Major depressive disorder is a huge public health problem. The World Health Organization has estimated that major depressive disorder is the leading cause, and I repeat, the leading cause of disease-related disability among women worldwide. So among all of the illnesses we've been speaking about, it's this illness, major depressive disorder, that has a huge public health impact in terms of disability. This slide I like to think about as an epidemiologic injustice slide because it shows how the prevalence of depression in women is twice that in men across the life cycle. So you see the lifespan here, and it is right about puberty that women develop roughly twice the rate of depression as do men. And the injustice is right at the time when women are having children, and postpartum depression contributes to this, the prevalence of depression is very high. So you think a time when women are childbearing, all the joys of childbirth, but for many women, those joys are not so obvious. Another peak is here in the roughly 1 year period before menopause. The perimenopause, there's another peak of depression in women. Roughly 1 out of 5, 20% of women will have an episode of depression in their lifetime. 1 out of 8 men. That means in this audience we have many of us who have had or will have experience with major depression. In terms of improving outcomes, what I'm going to speak about is considering the differential diagnosis, most prominently differentiating unipolar from bipolar depression, treating to remission, that is good, solid wellness, not just a response, measuring symptom improvements systematically with a measure that allows you a numeric quantification of symptoms, using evidence-based interventions, personalizing the antidepressant choice to the individual woman, optimizing doses, and then I'll talk about special consideration for women with reproductive-related depressions. That is, there's a subset of women who have this propensity to develop symptoms during times of hormonal instability. So that would be women who are pubertal and develop illness during pregnancy, postpartum, premenstrually, and during perimenopause. Now, in this slide set, you'll find many references both through the slide set and at the end that provide materials for you as a practitioner. And it's also important to provide self-help resources for your patients with depression. So what is this illness, major depression? I think that it is rather poorly named because, in fact, we do not have to have the symptom of depression or sadness to have major depressive disorder. One of the two symptoms that you must have are depressed mood, that is, sad, down, depressed, affective state, or diminished interest or pleasure. So one of my patients recently was a grandmother who had brought beautiful colored skeins of yarn to knit a blanket for her new grandbaby. And she eventually lost interest in making that blanket, couldn't pick up the yarn, had no interest, no motivation to make that blanket. But she was not sad, she wasn't crying, she claimed not to be down, depressed. But this lack of motivation or interest or pleasure is a second gatekeeper criterion for this disorder. So to have major depression for a period of at least 2 weeks, nearly most of the day, nearly every day, you have to have 5 of these symptoms, and one must be one of those gatekeeper symptoms. I think of this illness as a whole body physiologic dysregulation illness. And my evidence for that is the next 3 symptoms. So where in medicine do you have a disorder like this, where there are 2 poles of symptoms, so that weight loss, weight gain, relative to the woman's usual self, count as symptoms, psychomotor agitation, being unable to sit down, being very active, or like the grandmother I told you about, so slowed down she could barely move, or sleeping too little, not able to get to sleep, or sleeping 20 hours a day, again, like the grandmother that I told you. So depression has many phenotypes. One is this activated weight loss, agitation phenotype, which is very common in postpartum women, and the other we call atypical depression, sort of slow down weight gain. Low energy, not able to move kind of depression, and yet those phenotypes are the same disorder. Again, physiologic dysregulation disorder. Feelings of worthlessness, guilt, energy loss, difficulty concentrating, similar to what one might experience in jet lag, feeling just a step out of sync with the world, and recurrent thoughts of death are common. So again, an illness that I think is poorly named with several different kinds of phenotypes, and again, very common in women. So one important differential diagnosis, I would say the most important one, is differentiating unipolar depression that I just described from bipolar depression, where those episodes of depression alternate with not only a normal mood state, but with a mood state that is elevated, activated, above normal. So what I typically ask patients is, all right, you've described this depressed phase, and you described normal mood state. Do you have a period of time for several days where you feel like you drank several cups of coffee, you're activated, energized, talking too fast, people think you're moving too fast, you're interrupting people, you're getting a lot of things done, you have less need for sleep but still feel rested. Sounds like something we all want. In its mild form, it's hypomania. Many of these folks are very functional. But again, these alternating mood states and hypomania certainly can progress to mania, which is a very uncomfortable mood state. The reason it's so important to differentiate unipolar from bipolar disorder is that monotherapy with antidepressants is not an appropriate or evidence-based treatment for bipolar disorder, and in fact, it can increase rapid cycling of the illness. And one of the clues to bipolarity is that when you ask your patient whether they've been treated with an antidepressant before, if they've gotten agitated, activated, wired, that's a potential marker for bipolarity. The other crucial factor is family history for bipolar disorder. This diagnosis is difficult to make, and it's usually about 10 years before women with recurrent depression are diagnosed truly as having bipolar disorder. You can screen for it. We do have a screen, the Mood Disorders Questionnaire, which is referenced here. Now I want to talk about treating depression. And we in psychiatry use a lot of confusing terms. So we talk about these R's, relapse, remission. Essentially what this means is, this is normal mood, the woman becomes depressed across time, and what we want to do is put something in this acute treatment space to help her move, any kind of treatment, to help her move back up to feeling her usual self. 50% reduction from her worst symptom level is referred to as response, and that unfortunately has been used as an outcome in many randomized trials in psychiatry. We now know that the goal must be remission, back to normal mood state, because, and it's pretty evident that if you're only halfway better, the likelihood of sliding back is much higher than if you're fully well, and that's called relapse. We, again, are after remission, good, full return to baseline. If a woman achieves remission after an episode of depression, we continue whatever the treatment was in a continuation phase for at least 6 months, because if we don't, the likelihood of sliding back is very high, and if she does, it's again called relapse. Recovery is after a period of continuation of at least 6 months when she's remained well. After that, we call it recurrence because it's a new episode. If a woman has 3 or more episodes of major depression in her life, she's greater than 90% likely to have another episode, and it can become a chronic form. She's a candidate for maintenance treatment. Another way to improve your care of depression in women is to use a measure that gives you a numeric, a quantified estimate of her symptoms. And there are a number of very easy, quick, self-report measures that are free. Any of these are reasonable to use so that when she comes into your office before you start treatment, you have a sense. Her symptoms are on the scale quantified, and there's a number that tells you where she is. As your treatment unfolds, you repeat that same measure and determine, is she a little better, or is she really fairly asymptomatic and in good remission, which is the target. So often we see women who come into the office and say, yes, well, I'm better. But what does that really mean? And again, I'd like to push you to really work to get her to remission of symptoms. What about treatments? There are a whole number of different kinds of evidence-based psychotherapies. They are as effective for mild to moderate depressions as are medications. And in fact, there's some debate about whether medications are effective for mild to moderate depressions because there's a high placebo rate. These therapies are available in academic settings. When you get into rural communities or high-risk patients or patients who have difficulty making appointments weekly to get in for an hour session, women with many children, women with transportation difficulties, it becomes somewhat difficult to provide psychotherapy. But in the UK, there is a Beating the Blues program, which is a computerized therapy that is supported by the National Health Service, and that has just been translated to American, because of course the British don't think we speak English, so it's been translated. And our system and others are now striving to make computerized therapy, which is usually supervised by a coach, available to women who can't come in for appointments. So some wonderful things on the horizon. What about antidepressants? We've had a number of new antidepressants over the last several decades, and the reality is that any of these antidepressants have roughly the same ability to produce response and remission. So they're all roughly equally efficacious. Despite all of the ways you hear about they work on different neurotransmitters, the reality is they roughly produce the same rate of response and remission in groups of patients. But there are some clues to medications that you might use for certain kinds of difficulties. So, for example, the woman that I saw, the grandmother who couldn't knit, I gave her this medication, bupropion, because it acts on these two neurotransmitters. And for her atypical, that slowed down anergic depression, I felt this was a better medication for her as a first-line drug. The older tricyclics that act on norepinephrine aren't used much anymore because they're toxic in overdose. However, they have the advantage in that particularly this drug has very well characterized serum levels, so that if you have a patient who you're not sure about compliance or who's undergoing some complex medical situation like pregnancy where the dose changes, or we've looked at patients with bariatric surgery, pre and post-surgery doses change, sometimes levels can come in quite handily. These are the drugs most commonly used, the SNRIs and the SSRIs that act on serotonin. And in fact, women with primarily have mood with a lot of anxiety symptoms, and typically by the time they reach the childbearing years, many women already have recurrent episodes of depression, usually built on an anxiety disorder diagnosis that began in childhood or adolescence. But again, all of these medicines, essentially, if you give them to a group of patients, they act, or they have the same rates of response and remission. One of the ways I select medications as well is based on side effects. So if you take a serotonergic drug, the woman is more likely to have sexual dysfunction, GI effects. You pick a tricyclic, they're more likely to have dry mouth, tremor. You pick the drug I do, the bupropion, you're more likely to have these effects. Again, the reason I picked it for that patient is she was slowed down, had no history of psychosis. And appetite suppression is interesting. It is an agent, bupropion, which is the one that's least associated with weight gain. So that tends to be a reasonable choice for women who are worried about weight gain, and or it's also indicated for smoking cessation. So sometimes you can get a twofer with your treatments. Another evidence-based therapy that is not very well appreciated, nor do we have many mental health practitioners who practice it, is bright morning light therapy. You all have heard about it, I'm sure, for seasonal or winter depression. There are several decades of literature that show its efficacy, but less appreciated and confirmed by several recent meta-analyses are its efficacy for non-seasonal depression as well, which makes it a very interesting treatment for pregnant women, for women who decline medications. It's also effective as an adjunctive treatment, so that if your patient cannot tolerate a higher dose of a partially effective antidepressant, it's a reasonable therapy to add. These kinds of light boxes run about $200 or so. They're fairly inexpensive, commercially available. This website is a professional website run by my colleague Mike Terman out of Columbia. It contains professional free chat rooms. So if you're using Light and you have questions about its implementation, you can get a professional consultation on that site. And there's now an excellent, easy to read, doesn't contain a lot of alphabet soup. I mean, it's really a practical clinician guide for light therapy available as well. So let's move back to this concept of women across the life cycle and the subset of women who seem to have a propensity to develop depression during these times of hormonal change that we all experience. And I wrote a chapter about this, and I called it the longitudinal laboratory of women's lives because I like alliteration. But I was also kind of poking a bit of fun at our history from decades ago, where scientists were not very interested in including women in studies because we're messy, right? We have menstrual cycles and pregnancies and postpartum periods, and those hormones mess up all the outcomes. In recent years, those situations, these reproductive events have been recast as incredible opportunities to study the impact of hormonal changes on the brain. And what we know is that women who develop postpartum depression or premenstrual dysphoria, if you look at the reproductive hormone levels in their peripheral blood, the women who are ill don't differ from those who are. What is happening is that at the neurobiological level, that woman's individual brain chemistry, there's a subset of women who seem to become destabilized in this way we call major depression with all of those symptoms. They have a higher propensity to become destabilized in that way. So what about premenstrual dysphoric disorder? Common illness, I'm sure you see it frequently in your office. A lot of folks feel like this is not a very serious disorder, but in fact the symptom levels of women with premenstrual dysphoric disorder in that luteal phase are very impairing, particularly irritability. So I have had patients who come in who are functional CEOs, and the week before their period, they're smashing their fist through glass doors. Just extreme irritability in very severe cases. It needs to be treated across time, and typically when treatment is stopped, the disease comes back, and it has a progressive course often across the life cycle. Most women know when their periods are coming, and you have this sense, you have some symptoms. Lesser intense forms of premenstrual difficulties with lots of possible symptoms is typically called PMS. But premenstrual dysphoric disorder, this more severe illness I'm talking about, is roughly 5% of women who have this regular cyclical mood disturbance. And it looks like this. And this graphic is important because when you're doing research with premenstrual dysphoric disorder, you typically, or you want to have a couple of cycles plotted, and you ask the woman to do a daily rating scale, and there are standard scales for this, and you track mood and other symptoms across the menstrual cycle. And this is a typical pattern. So a menstrual bleed, minimal or no symptoms in the follicular phase, sometime like clockwork in the luteal phase, those mood symptoms jump up again. And that happens over and over again. And you can see how difficult this would be for women with this disorder. What is very important is if you see a pattern where the symptoms are here, get worse, here get worse, that is not premenstrual dysphoric disorder. And if you say, I want to treat premenstrual dysphoric disorder, the majority of women that you will get will have that pattern, which is typically major depressive disorder with premenstrual worsening. But it is not premenstrual dysphoric disorder. And the distinction is important because this illness is not just sort of a variety of depression. It's different in that the only drugs that work better than placebo are serotonergic medications. So we talked about a variety of medicines that work for major depression. For this disorder, it's the medicines that have serotonergic impact. The other thing that differentiates it from major depression is that it can be treated only during the luteal phase. So many women can be treated only during that symptomatic phase, which again tells you that it's different than major depression, because typically after a couple weeks is when you're finally beginning to see some response for major depression. And that probably has to do with different pathophysiology of this illness than major depression. So what about pregnancy? Women are bearing children older in the life cycle. We see many women now with a pattern of recurrent major depression, many of whom are on maintenance medication when they're thinking about pregnancy. In this study that was done by the Harvard group, they evaluated what is the risk for recurrence if a woman discontinues her antidepressant proximal to conception. And again, these are high-risk women already with an established chronic course who are being treated with maintenance medication. If they discontinued their medication, it was 68% risk for recurrence, and it was a rapid recurrence. So it wasn't like they could sort of make it through most of pregnancy. This is also, though, something that I think is difficult in that women who continue their medication, still 1 out of 4 of them relapse and are recurred. And that's, I think, potentially due to the fact that we need more information on adequately dosing women during pregnancy, and I'll talk about that a little bit later. In the media and on your screen at night about call your attorney if you've been exposed to any medications. I'll now talk about my take on this literature, and certainly SSRIs, along with anticonvulsants, are probably the most studied medications in pregnancy, in part because the disorders are frequent in women of childbearing age. What I always emphasize is that these medicines are not used in a vacuum, so they're used to treat major depressive disorder, anxiety disorders, whatever psychiatric illness it is. All of those illnesses, again, physiologic dysregulation syndromes that have their own sequelae for pregnancy. So what you typically get is the woman who has the illness and all of its state, like do they have it now or have they had a history of it? They have that coupled with medication. So you're really looking at a couple of exposures, much like if you were looking at a medication to treat diabetes in pregnancy, you would want parameters for control of the diabetes before you assumed it was the medicine. Okay, so what do we know? And this is my take on the literature, my opinion. So for intrauterine fetal death, is there a relationship between SSRIs and intrauterine fetal death? Certainly there's no conclusive evidence, and this is very difficult to study, as you can imagine, the relationship of miscarriage to SSRI treatment or depression. And there are studies that claim that there's a higher miscarriage rate in both, but the distinction between what's the depression and the medication has never been adequately clarified. So what about physical malformations? Well, I think the best summary was written by Michael Green in the New England Journal in an article entitled Teratogenicity of SSRI, Serious Concern or Much Ado About Little. And his sense was, of course, the latter, and that specific defects, if any, are rare and the absolute risks are small. This editorial was accompanied by 2 large-scale case control studies in the New England Journal in the same year, both of which showed that overall SSRI treatment was not related to the majority of defects that had previously been a concern, and the defects that were seen in each of these 2 studies were different. So in this literature, it is absolutely impossible to say SSRIs have 0 impact. on reproductive outcomes. The best we can do are these very large epidemiologic studies and look at the absolute risks and are there consistencies and defects across studies. So for these medications, if there is any risk, the absolute risk is very small, and it is impossible to separate those risks out from the risks of the underlying illness. In terms of growth, there's good evidence now that SSRI exposure in pregnancy incurs a risk of roughly twice the rate of preterm birth in exposed mothers. However, exposure to untreated major depression incurs the same risk. And in fact, in a study we published a couple of years ago, the rate of early and late preterm birth was 20-some% in women treated continuously with SSRIs in pregnancy, many of whom were functionally much better, and women who had continuous major depression in pregnancy, those risks were the same. So if a woman says, I'm worried about preterm birth, so I don't want to take an SSRI, if she becomes depressed again, she hasn't saved herself that risk, and she hasn't incurred a whole other set of risks due to uncontrolled disorder. The good news for long-term behavioral studies, of which we have few, is that those available consistently show that the mental development of children exposed to SSRIs in utero is not distinguishable from unexposed children. That part's good. There are two studies that show that the exposure to SSRIs may produce a slight delay in development of motor milestones, but still within normal limits, and some of Virginia Casper's work has picked up some very mild tremulousness, fine motor difficulties in exposed infants in toddlerhood, the long-term course of which is not known and it's not been replicated. We have data we're looking at now for our sample of a couple of hundred toddlers where we're looking at the same data. So in a couple of months, I should be able to add to that literature. Neonatal syndrome, transient, 2-week, restlessness, rigidity, tremor in infants exposed to SSRIs. They have roughly twice the risk as unexposed infants, and these two drugs are the main drugs associated with that syndrome. Paroxetine and fluoxetine, very short half-life with any cholinergic effects, and you get cholinergic rebound, long half-life drugs. And these two are the drugs most associated. But again, it's transient. So if the woman responds to just those agents, keeping her well in pregnancy is crucial. Persistent pulmonary hypertension of the newborn has been reported to be increased, again, very low absolute risks, an increase 1 to 2 per thousand to 6 to 12, and in fact, some more recent studies, some have replicated this finding, others have found no relationship. So we're in that low absolute risk territory again. When you're treating a pregnant patient, the tendency is to say, she's pregnant, just give her a low dose to kind of get her by. I would urge that if you're going to treat a pregnant patient, you believe it's because treating her disorder gives her the best potential for the outcome, best potential for a positive reproductive outcome. I would treat her to remission. Use the dose, a minimum effective dose, with effective being the operational word. And here's why. These are some data that we published for serum levels corrected for dose across pregnancy. You can see at 20, 30, 36-week delivery, the levels go down. And if they go down below the point that works for controlling her physiologic dysregulation, depression in her brain, she will get sick. So it's very likely that as you monitor your patient with that systematic measure across pregnancy, that numeric measure, you can pick up when she's beginning to relapse and keep her well by increasing the dose. This is the same data for the drug citalopram. It's citalopram and its metabolites, but the same pattern of decreasing levels across pregnancy. So what about postpartum depression? We screened about 10,000 women at the Women's Hospital in Pittsburgh. 14% were positive on our screening measure, 1 out of 7 moms. We were able to do home visit, careful assessments on 800 some of these moms. We found that the frequent time of onset, the most frequent was postpartum, which again, we know is a very high-risk time for women. A third of the women, though, were depressed, became depressed with pregnancy, and many of these, about a fourth, were chronically ill. So if I had to do this study again, I would definitely add a screening at the first prenatal visit to pick up these more chronic cases and new onset cases and spare these women a pregnancy that's marked by depression. In terms of medications, treatments for postpartum women, we conducted a study to look at two different medicines, an old tricyclic and the medication sertraline and SSRI. Essentially, we found what I told you before. They produced non-significant differences in the rates of response, in remission. There were no clinical predictors to tell us which drug was the best to use for which patients. Even the side effect burdens were the same. So what the women reported as far as burdens was exactly the same, although the side effects were different. So the women on nortriptyline had dry mouth, or business with skin, constipation. The women on sertraline had headache, GI effects, and sexual dysfunction. But the burden was the same. So these medications in general work for depression no matter when it occurs in the life cycle. And whether you're postpartum or perimenopause, the medications work. Now, one point I would make is this one dose does not fit all. I see many women who come to me who have been given a prescription for 50 milligrams of sertraline for postpartum depression for 30 days with 6 refills. The starting dose of an SSRI. And in fact, in this study, which was blinded, where doses were increased, unless the women met criteria for remission or had prohibited side effects, we're looking carefully at dose. We asked the question, for sertraline, of the women that remitted, what dose did they take? And in fact, only one responded to less than 50 milligrams, and the majority took 100 or more. So again, with that systematic measure across time with the numeric value, you can see, is the woman really getting to remission? Everyone knows childbearing, having a child, giving birth is a huge endocrine situation of massive withdrawal. And so a study had been done in England to look at estradiol treatment for postpartum depression in '96. And this is getting into what is the hope in terms of thinking about these reproductive related illnesses and the utility of hormonal treatments. So they used transdermal 17-beta estradiol and showed that, in fact, in very seriously ill women, the response to that was much better than to a placebo. We are now doing a replication of that study, transdermal estradiol patch versus placebo patch, with a drug comparator of sertraline to see if we can create data to ascertain the role of transdermal estradiol in the treatment of postpartum depression. And in fact, you could argue that this study should have been done first in perimenopausal women, and in fact, we use data from perimenopausal treatment of depression in women with transdermal estradiol to justify this study. And again, for perimenopausal depression, you can use the standard antidepressants, which typically be the first line of treatment. However, there are some women who benefit from augmentation treatment with estradiol, and some women who refuse antidepressants. And in some academic settings, estradiol is being used as a treatment for perimenopausal depression. There are a couple of randomized trials and another more recent one out of Harvard in which the responses appear rather dramatic. This is a much higher response rate than one would get for a typical antidepressant, but again, larger trials and the true place of estradiol for treatment of these illnesses need to be considered. So just summarizing and ending, there's a lot of steps to improving function in women. So the first is detection, finding these cases. The reality is in America now, the vast majority of men and women are neither identified or treated when they have major depression. The diagnosis is complicated and needs to be differentiated from unipolar illness. So we need to do more with reducing stigma, treatment engagement, working with the patient about the treatment that she prefers and will actually take, monitoring treatment to show that with our serial measure she really is getting better across time. Because what we really want is that improved outcomes so that her function in society can be maximized, because we all know women are really the ones holding up the world. I'll finish by inviting you to the next meeting of the Marseille Society in Paris this fall. Please come, and I'll be happy to answer any questions.